Deborah Bullock. I'm a clinical safety consultant with the Association of Ambulance Chief Execs. Not the chair, because that is far, far more important than me, and certainly above my pay grade. I was up to last month the chair of the National IPC Leads Group for the ambulance sector, to some of my esteemed colleagues that are in the room. And as from this month, that's you. Are you going to introduce yourself?
Yep, I can do. I'm McCluskey. I'm the new IPC manager for the North East Ambulance Service. Was the lead practitioner for Scottish Ambulance Service for 6 years prior to that. And as Deb says, I've took over as the interim chair for the Ambulance Service Group for IPC.
So both of us worked in the ambulance sector for many years. Mine is over 31 years with North West Ambulance Service, formerly Cumbria. So I apologise now if you can't understand the accent. And I have always worked either on the road as a paramedic or at some description within IPC. IPC within the ambulance sector is something that is very different to any other sector. So hence why we just thought it was important for us to basically give you a bit of an insight into what it's like to work within the ambulance sector and particularly within IPC. So the first thing I wanted to ask was, who isn't from the ambulance service in here? See, mission accomplished. Thank you very much. Because the whole idea is we always complain that there's very few ambulance things set up at these sort of events. So when we were given the opportunity, it was a real thing of, actually, what we want to do is address you. I love these people to bits, but they know everything we're going to talk about anyway. So this is more for you, just to give you a bit of an over-flavour of what it's really like, some of the challenges that we have, and some of the things that you might not necessarily think are applicable to you or applicable to us, but we have to condone and put up with and everything else. The other thing to say is this is a very open and honest conversation. As you can probably gather, I will try to be as politically correct as possible. I apologise if working in a vehicle and working on an ambulance service is very different. So when you've been brought up with this, we are a bit of a strange kettle of fish. And it is sometimes a bit hard to get your head around that. So I apologise if I do come across as a little bit flippant sometimes. We all have that sense of humour, I'm afraid.
It is going to be a bit of a whistle-stop tour of the differences in IPC from the pre-hospital setting to the hospital setting. So if you do have any queries or questions, just write them down and we'll fly through this as fast as we can and then answer the questions at the end. What we might do as well, because there are experts in the field right in front of you, if you'd like to put your hands up, whoever yous are. I knew none of them were going to do it, no. About the first 4 rows are all ambulance service IPC specialists. So if there is a question which we need to defer to those, we will defer the question to those. I will try and keep us on time as well, because we love to talk, and we've probably already gone a few minutes behind already. Just tell me when to click.
Press the button. So so this is some of the things that we want to talk about. We just want to give you a brief overview of the workforce, the estates and fleet, a little bit around some more acronyms. You think the NHS is bad for acronyms, and ambulance is 10 times worse. A little bit about the clinical issues that we have and the clinical challenges that we have from an IPC perspective. A little bit about pandemic planning. This isn't a post-COVID wrap-up. I'm sure we'll be here all day if it was. And just about where we want to focus on and what we want to be doing going forward. See, I managed that bit. All right. So this is where I need to get closer to that so I can actually see it. So IPC workforce. We have... I could have asked and said, do you know how many ambulance trusts there are around the UK, but I've actually put it up on there. There is only 14, plus or minus a couple of the little islands, Isle of Wight, Isle of Man, Guernsey, Jersey, but 14 core, including the devolved of Wales, Scotland, Northern Ireland as well. And we are a very close-knit IPC Leads group because there's very few of us. And there's very few staffing in amongst that as well. So in itself, that is a challenge because we are trying to get a consensus spread out IPC right across the whole of the Ambulance Trust. But also as a positive, it means that we do talk regularly. We don't have the issues that many other NHS have, is that you're all doing something slightly different. Within the ambulance sector, what we've really tried to achieve and aim for is consensus agreement for all our IPC guidance and guidelines. And certainly during the pandemic, that was probably one of the best things that came out of it, was the fact that we all worked much better together. And therefore, you can guarantee when you go anywhere that the Ambulance Trust in X, Y and Z will be doing the same as it is in, you know, from top of Scotland down to the bottom of England. There is the odd variation with the devolved nations, but generally we all try and work well together. There is no IPC team, blueprint of what it should look like within the ambulance sector. And unfortunately, we are very thin on the ground. Some services have got lucky. We've got maybe half a dozen people working in an IPC team, and in others, there's literally one person. Now, if you think about it from a geographical point of view, and going from your own experience, North West Ambulance Service covers the top of Cumbria down to the bottom of Cheshire, and over including Manchester and Liverpool and Cheshire and Mersey. Having only 2 or 3 people working in a team is a real challenge to try and get out to those 7,500 staff. So from an IPC challenge perspective, how do you get those IPC messages across when you've got so many thousands of staff to do it in, and you're all spread over such a geographical area? Pre-pandemic state of preparedness and post-pandemic. If we had to be honest and say what was, from an ambulance sector generally, our pandemic preparedness like before the pandemic, being honest, I would probably say it was pretty pants, generally, and I don't think there'll be many people that would disagree with that. We do try, but again, we've got our own challenges. Certainly, fit testing was one of the biggest things that I think we all struggled with. Again, not because we weren't aware that we need to be doing it, but operational issues, the demand on the service, trying to get staff released in an area where they are out on the vehicles all the time. We don't have, you know, a lovely little hospital training where we can get everybody in and do this. We don't have pools of people that can go around the services and able to train our staff up in fit testing. So that was one of the big challenges. Post-pandemic, has it got any better? Probably not. But we are aware of it, and we are trying to encourage that getting better than it used to be. So there's a few things like that. The other things around audits, you know, it's on with NWAS, because that's the only one I know. There's 120 odd stations. How do we get to every single ambulance station? How do we get to the hundreds of vehicles to audit them? How do we get in there to actually not just turn up with your tick sheet and work your way through it and be realistic on what we want to see and what that compliance is really like? So we rely very much on our operational colleagues to go out and do that for us. And sometimes, you know, it's great having a piece of paper that says you're 96% compliant in hand hygiene, but are we? No, we're not. So again, some of our challenges. Resilience, sustainability and succession planning. Luckily, because of the education framework, I think we've got a bit of direction now. At least we know that we can set the teams on with a profile and something to work to. Up till now, IPC team within any service and any NHS trust is probably seen as, well, certainly within the ambulance sector, as the IPC police. We're always there just to sort of go along and tell everybody to take the watches off, and probably not there as a positive thing. And we are really trying to change that culture and change that ethos behind it. By hopefully getting people to work with an IPC team that want to work with an IPC team, rather than somebody that's just been brought off the road because they've got a bad back or whatever and forced in to come and work for us, is something that we're now well behind. But usually that's how we all ended up in the jobs that we did. And the education framework will help with that. One of the other things the other challenges that have just come up is around our occupational health standards and our occupational health teams. We all have different occupational health. Some are in-house, some are out-house. Some are based within the same headquarters as everybody else. Some are remote working. when you have 5 different ambulance trusts that have merged into one, are all the occupational health records up to date? Absolutely not. Do they have the occupational health records from some of our old colleagues? Absolutely not. Things go missing. And the problem being with IPC is that occupational health is seen as part of our role. So if there is any management conversations to be had around, well, this person needs to be off, or, you know, what's their immunisation status, they will come to the IPC team, they won't go to occupational health. So we have to try politely say, actually, that's not anything to do with us, go and speak to somebody else. But 9 times out of 10, it'll fall on our desk anyway. Vince, anything from you on that?
No, not that I can think of, although I was supposed to add something, but it's gone out of my head, so it'll come back. I'm going to press the next button, and I've left me varifocals on, so I can barely see the screen now, so I'll probably fall off the front of the stage at this point. And Debs will have to whisper in my ear what I'm reading next. So part of the issue that we have, this is happening already, I'll go that side of you.
I'm not going to say who's Laurel and who's Hardy, but there you go.
If you see you just whispering in my ear, you should just keep me right on the slides. So part of the issue that we have are estates and fleet. So where normal IPC teams have responsibility for, you know, your clinics and your rooms within a static building, we've got the ambulance stations that we've got to look after, which are housing all the ambulances, and also the fleet. And that's not just your road ambulances that you see, that also includes fixed wing aircraft and your rotary aircraft if you are working in Scotland, because Scotland Ambulance Service has a responsibility for those aircraft. So one of the stories that I used to tell Debs, I got a phone call one day just to say, oh, there's been a bit of an accident with the helicopter and we don't know how to clean it. So I said, no problem, just send me a picture. And while they're out on flight, a seagull flew through the window, hit the back of the cockpit and exploded. Sorry, this is just after your dinner. This is the perfect time to say this. And basically exploded over the back of the helicopter. So these are the issues, and you know, there isn't a manual that you go to and think of, right, seagull exploding in back of helicopter. And even down to the point where some of the normal information that you would say is, you know, let's get a cloth, let's wipe it up, we'll do this, we'll do that. We have to have discussions with the Civil Aviation Authority, because you can't use the same chemicals on a plane in a helicopter that you can use on the back of an ambulance. So there's all those slight variations that you have to take into consideration. Again, we've just discussed premises and vehicle design, the age profile. We have very, very old ambulance stations across most of the UK, and the vehicles are quite an age as well. Now, within England, all of the vehicles should be of the same standard due to the Lord Carter report, where in the developed nations they are slightly different. But again, it's, do we get involved at the right point in those discussions? So quite often we'll get involved at the end of an implementation and say, was this done right? Instead of being at the front end saying, actually, we wouldn't recommend that that is put there, would recommend something else from an IPC point of view. Some areas have make-ready systems for the vehicles, which is really useful, where the vehicles are, they'll go into a central area. Sounds awful, the vehicles are basically reprocessed, cleaned, stocked. There's no clinician involvement. The clinician comes on for the next shift, just walks into the ambulance, and then they can go out and do that straight away. That works really well in a lot of areas, but some areas don't have that. Some areas we still have the vehicle stood down and the ambulance crew are cleaning the vehicle rather than being out dealing with patients, because that's what's been agreed. The fleet should remain no older than 5 years old, but that doesn't happen in a lot of occasions. The fleet has to be extended, especially at the moment as well, when there's problems getting like products worldwide. That does affect the ambulance service as well. So now if you want an ambulance, you're looking at probably a 2.5 year wait. If you ordered it now, you know, it's 2.5 years before that you'd get that ambulance delivered. So it's quite a significant time before we can get these things in. And things change. So just before it gets delivered, there's an IPC rule changes. We have to go back and say, actually, can we have it redesigned yet again? So we've got emergency and urgent care, PTS, patient transport, the kind of day-to-day taking people to clinic appointments, the specialist operations fleet, so that's the hazardous area response teams that go, you know, into the more dangerous areas. So if there's been any entrapments, if there is a terrorist attack, these people go into the hot zone, remove the patients to the colder areas where the normal clinicians can deal with those patients. But those have to have specialist ambulances created as well. So again, that's not an easy thing to do.
And ballistic vests and helmets and all the uniform that comes with that. They don't come with a wet wipe.
That's right. So also we have sustainability. We are, we do try to do what the rest of the NHS is doing, look at the sustainability side of things. But when you've got a vehicle that can be no more than a certain weight, it can't go over that. We can't have 3 different waste bins in the back of an ambulance. We don't have the space. And I know it sounds strange that, the 2 waste bins won't knock you over. But if it was just 2 waste bins and then just an extra thing here, and every department asked for one more little thing, very quickly we'd be over the weight limit that would be allowed for that style of vehicle. That's the other thing that we have to bear in mind. We fall under the road legislation, so our vehicles have to be within a certain weight. An NHS standard of cleanliness. Although it has been released for everybody else, there's a specific NHS standards of cleanliness for the ambulance sector. It hasn't been released yet. We're still waiting for that to be released. So we're having a discussion earlier on about that, where we've got contracts which are waiting to be renewed, but we're struggling to renew those contracts because we don't know what's going to be in the NHS cleanliness standards for the ambulance service. So that's a wait and see. Hopefully it happens soon, but we won't know about that. I'll hand back over to Debs, I think, when she clicks.
So just to give you a little bit more flavour of where we fit in with everybody else, as we say, we are NHS. We have been part of NHS for many years, but we're also seen as a little bit of the blue light services as well. But the biggest thing is we work with the National Ambulance Resilience Unit, or NARU. And NARU is government-led, and they are the ones that traditionally deal with all the pandemic and the big vehicles, your major incident vehicles, etc., etc. And historically up to date, there wasn't really a lot of conversation between NARU and the IPC teams. Over the last couple of years, and certainly with the pandemic, that's really helped move things on so that we are actually now having those face-to-face conversations and discussing those specialist vehicles and whether we can have sinks in vehicles and welfare vehicles, and can we have this and can we have that. Where before it was, there's your vehicle, that's it. Where now they are actually saying, can you come and talk to us about this? How can we do this better? How can we get involved? So the National Ambulance Resilience Unit, they provide the safe systems of work for those specialist major incident type vehicles. They historically have always been the ones that will do any infectious disease transfers. If we ever got a query Ebola, MERS, or whatever that might be, it was always down to our HART teams, our hazardous response teams, that would be the ones that would be designated to be able to do that. That went slightly out the window with the pandemic, as you can imagine, and therefore it was very much down. We had to make sure that all our vehicles and all our crews were trained to the same standard to be able to transfer any suspected or positive infectious disease patient right across the board, unless it's from one specialist IC unit to another. It's always still done by our normal day-to-day crews. So 1 minute they're dealing with a cardiac arrest, the next minute they'll get a call to say we've got a suspected MERS patient or a COVID positive patient or whatever that might be, and they've got to change their mindset and their usual PPE to be able to go and deal with that. One of the things that we also do is working with the Association of the Ambulance Chief Execs. As I said, for the last 3 years I've been the National IPC advisor for the ACE, and our role is very much about pulling those trusts together, making sure that we are all comfortable as IPC leads with the guidance that's come out from UCSA, Public Health, NHSE, and made to sure that it's fit for purpose. Particularly during the pandemic, that wasn't the case, and because the guidance is very generic. So our role, my role, was basically to take that information and make it ambulance friendly, put it into ambulance speak so that our road crews could say, actually that works for us. Changing terminology from everywhere that it said gowns, changing it to coveralls, for example, because we don't use gowns, we use coveralls. And little things like that that really could irritate people. So hopefully it's trying to address those little things that isn't such a big thing you would think, but makes a difference to our staff because they make them feel like they're involved and wanted. So that lead role was only up till the end of March, unfortunately. So we are all now back to each of the ambulance trusts working together, but without having that central person to be able to try and pull it together. But we do, and we have issued lots of consensus statements and position statements over the last 2 or 3 years on every subject that you can sort of talk about in relation to IPC, just to be able to set that message across to our workforce, but also to our trade unions, because the ambulance sector is quite trade union heavy, just so we get that agreement that we are all comfortable with what we are doing and delivering. And we do undertake peer review programmes of each other. So we go into each other trusts and assess what their IPC is like, looking at what ours is like, picking up best practice, as well as highlighting any things that might be useful to amend or update on. So that's it, really.
Just checking everybody's awake, because the session after dinner is never the best session to have. She was going to click. I knew she was going to do that. There's a part that we missed, which was Epi shuttle mobilisation and response. Just in case anybody wanted to know what that was. Basically, the Epi shuttle is what we use to transfer patients to a high-level isolation unit. It's
like an open coffin.
I was trying to think of something technically better than an open coffin, but it does look like it's a Perspex open coffin. Yeah. Basically, where you can do all of the treatment in a safe environment. Kind of came into its own through COVID, was introduced through COVID, and some of the high-level isolation units do quite actually like them, and are still going to be using them. So at some point you might see them throughout your career. So, sorry, I'll press next now.
Don't apologise.
And I love how Debs gets really short slides and I get the really big slides. Kind of the IPC thing that we have to do as well is, again, it's not just the standard ambulances. We do have specialist practitioners who work within our organisations now. So we have merit teams, care teams, helimed, doctor-led assets, heart, and it's kind of, it's that clinical practice of we know what we want to do, and then the IPC standard, and then what takes priority. I've been involved in incidents where there's been open thoracotomies being done on the roadside. Is there an IPC consideration? Am I going to stand there? Did you do that? Did you do this? You failed your audit now. And then we've had open thoracotomies that have been performed in the back of ambulances where I've stood there and thought, this ambulance will never be clean ever again. And neither will the staff working in there. It was just horrendous. So there's those things that we have to take on board, and people will come to us and have those discussions and say, well, actually, but they didn't change the gloves here and they didn't do this, at that particular point. And it's kind of balancing that. Some of the areas that staff work in, we were having a discussion about glove use, and some of our staff go into areas which are absolutely like patients' houses, which are absolutely horrific, and some of our staff will say, I just feel like putting my gloves on when I touch the door because I know that I've been there before and there's been feces over the door handle when I've touched it. So although we should be, appropriate glove use and all these other bits and pieces, there's a variation in what they have to do because of the areas that they're working in. So I've kind of gone, the invasive procedures that we do, IV, IM, IO, needle thoracentesis, cricothyroidotomy. There's a whole scope of things that we have to be able to do, and we have to be able to perform these on the roadside as well. Again, a common thing, some of our sterile fields are sometimes in a field if a car's rolled over. And I've worked in these areas before when I've gone to do a procedure and I turn round and a sheep's running away with my sterile field and half me set up, and then you think, actually I've only got 2 needles in my bag, can I still use that one? Will anybody ever know? It's those considerations that you have to have. The clinicians in the room who've come from an ambulance service background, the amount of times when I've been getting pulled across the floor by a dog trying to put a line in, you know, and you think, you know, what am I going to do? I think I'm in, I'm getting dragged around, and I hate dogs, by the way, I hate animals. So those ones are a nightmare for me. But it is those things, you go to do something and a cat walks across your sterile field and you think, you know, I have just spent all of my time preparing this. And we aren't in an environment where we can just create another sterile field straight away. Yes, we can probably just go to the ambulance, but in a time-critical situation, what are you going to do? Now, I'm not saying what's right, I'm not saying what's wrong, but these are some of the considerations that our clinicians have to take on a day-to-day basis. I think I've gone further on. Environmental challenges, what was that?
That was just basically what you were saying
There
before.
we go.
You know, we do deal in pretty awful situations sometimes, and dangerous situations. If you're on the side of the motorway with a severe trauma patient trying to get a cannula in, you know, we're not going to get it perfect. So that is why a lot of the trusts have gone with cannulation packs that have got red stickers and green stickers. Green, as clean as it can be, it's never going to be perfect. Red, it's a dodgy one, you need to change it as soon as possible. It's got to be practical. And quite often it's that understanding between what it is for an ambulance perspective and what it's like from a hospital perspective. And sometimes those views don't necessarily tally, but it's everybody's got to understand that we are different, and therefore we've got to adapt to it and to our challenges.
The next group's coming in, so I've got a feeling we're going to start having to wind up, so I'm going to talk a little bit faster. So we also have the antimicrobial prescribing as well, again, which is sometimes we have to do it if we've got long limb fractures up in the Highlands. We have to take that consideration that we're never going to get them to a definitive place of care straight away. We'll give the antibiotic on the roadside. So again, there's some things that we do which don't sit within the natural framework would have been set up for everybody else. It will have been agreed. We do have medicines management groups within the ambulance services, so it will have been agreed, and we've got agreement to slightly work outside of some procedures. But again, these are the things that we have to take into consideration on a day-to-day basis. Hit the button. I think it might be you.
Okay, and again, I will just fly through this one. Again, pandemic planning resilience. All we need to do is make sure that we learn from COVID. And I don't think there's anybody probably in this room that won't agree with that. I think it has been a challenge for everybody, particularly for the ambulance service. We've got lots of different local, regional, and national learning, and we just need to make sure that people remember it. It seems to have been quite easy that people have slipped back into bad habits very quickly. Which we've noticed, and I'm sure other sectors have noticed that as well.
Please just come in and sit down. That would make us look popular, by the way. So that would be really good. Loads of you just come in and sit down.
So last year we undertook a IPC survey across all of the ambulance trusts, 7,500 responses, looking at what the learning was like pre-COVID, during COVID and post-COVID. The Zeal survey, the biggest highlight of it, and all I can say is if anybody's interested in it, please go and have a look on the ACE website. There's a QR code on there. It'll take you direct to the report. That report shows what everybody's understanding and culture and beliefs were, as I said, pre, during and post-COVID, and how things that we thought would be IPC, the learning from it is not IPC. It's very much around that cultural behaviour change. It's very much around management. It's very much around training in general and how these messages put across, very much around communications, and is a widely trust learning piece of information that we hopefully ambulance sectors will take forward going forward.
Shall we move on to the last one?
Yeah, and all I was just going to say on that was it is very much around collaborative working and getting those communications in early, trialling things out and understanding that we all need to get around that table very early on and not leaving us last to the table, which is what usually happens.
So finally, honestly, you've missed a really good thing. I've got 17 seconds. I feel like I'm at the Oscars. I'll thank everybody later. So let's revisit the basics and get these right. Refocus on the correct terminology and behaviours. Level 1, 2, 3. That's what we were using. Now we need to get back to standard infection control. Transmission-based precautions. What are those going to look like in the future? There are discussions that are going on and reviews going on at the moment. Looking at those. Promote individual dynamic risk assessments. We've had staff previous, especially who've just joined an organisation, who've been kind of spoon-fed all of the risk assessments. Now they're going to have to do these things themselves. Promote the application of the hierarchy of controls again. Gloves Off campaign right across the NHS. I know that's gone quite local in ambulance services as well. Promote compliance with bear below the elbow. All my ambulance service colleagues here will agree. We do not watch the ambulance service programmes because it's an absolute nightmare. It takes me about 4 hours to get through one episode because I'm pausing it and thinking, right, you're getting reported. You know, you failed your next audit.
Or shouting at the telly.
Yeah.
Yeah.
And IPC, again, you know, we all know this, is everybody's responsibility.